Okay, let's make a start. Good morning, everyone, and welcome to this session of the All-Party Parliamentary Group on coronavirus. It is in the midst of a purported tidal wave of Omicron, and so we have pulled together at a relatively fast pace, mimicking the virus, a esteemed panel of people who are hopefully going to shed a bit of light on what's going on. We've got 45 minutes done in a slightly different way this time. We're going to have some presentations, and then after that we're going to move to a second panel where we're going to be able to ask questions about what it's like on the NHS frontline right now. I'll introduce the second panel when we get there in 45 minutes, but let me start by introducing this one. We are very, very lucky to have with us three people who I'm hopeful will be able to help us in our ignorance. The first is going to be Professor Wendy Barclay. Wendy is a professor of virology and is head of the Department of Infectious Disease at Imperial College London, and is also a member of SAGE. Professor Christina Pagel. Christina is Professor of Operational Research, a brand of applied mathematics at the University College London, and Director of the UCL Clinical Operational Research Unit. Since May 2020, Christina has been a member of Independent SAGE and is a frequent guest on national and international media discussing the current COVID-19 situation. And we also have with us Professor Stephen Riker, who is a professor of psychology at the University of St Andrews. He's a participant in SPY-B, which is a subgroup of SAGE, and is in the advisory group to the Scottish Chief Medical Officer on COVID-19. So we are going to have roughly 10 minutes for each presentation. We are hopeful that the technology is going to work for us, followed by questions from parliamentarians until we run out of time. So if I might ask Wendy, would you mind having a go and seeing if the slides work? Over to you, Wendy.
Unmute myself. Okay, I'm hoping that you can hear me, and I'm going to put my slides to slideshow, and I'm hoping you can see the appropriate slides in the right view. Thank you, Leila. Okay, so I've been asked to speak from a virological perspective about Omicron, the latest variant of SARS-CoV-2, and just as a reminder, there have been a number of different variants which we have seen transmitting in the United Kingdom. The virus, of course, emerged late in 2019. We call that Wuhan-like. By the spring and summer of 2020, there was a key mutation which occurred in the spike protein of the virus and is really, in many ways, the reference strain for most studies now. And then by autumn 2020, we saw the start of the alpha wave in the UK. Of course, that variant emerged in the UK, and by that time, the World Health Organization had decided to name variants, and so this one got the first name Alpha. Alpha came and went. We had a little bit of beta variant in the UK, but this one never really took off in the UK. There were some cases, but it didn't transmit widely. And then by the spring of 2021, the Delta variant arrived and really has been the predominant variant in the UK at a fairly flat level since the summer, until, of course, in the autumn, we saw the arrival of Omicron, and that's what we're concerned with today. So some just basic virology, forgive me if you all know this already, but this is what this virus looks like. This is a sort of schematic of it. The bits on the outside, the corona of the virus, is the spike protein, and that's important because it's the constituent of our vaccines, as I'll explain in a minute. And then the line in the middle here is the genome, which encodes all the genes of the virus, everything it needs to propagate itself. And if you stretch that line out, this is the genetic map of the virus, encoding various important genes. For example, sort of proteases, which can be the target of antiviral drugs, which may be coming, enzymes which help the virus replicate, and then the important spike protein here and some other proteins that form part of the virus particle, like the nuclear protein further downstream, which I will refer to. So vaccines have been really the primary response, if you like, of human beings to this virus. And the vaccines work by inducing immune responses to spike, that part on the outside. Most of what we think about, and most of what I will talk about today in terms of vaccines, is illustrated here on the bottom right. So this is a sort of beautifully rendered image of the virus, and then these little Y-shaped molecules here are their antibodies which see the spike. And the idea is that these antibodies coat up the virus and stop the virus from infecting cells. They coat all around the virus particle, and then the virus can't attach onto the cell surface receptors, and you block infection. And if you don't completely block it, if you don't get complete sterilizing immunity, then at least as the virus tries to replicate, the idea is that the antibodies would mop up a lot of the virus particles and the viral load would be less. But there is another important arm of the immune response, which is illustrated on the left-hand side here, which is the T cell response. And what T cells do is they come and they recognize virus-infected cells, because the cells themselves put out a signal to the T cell, a very specific signal to say, I am infected, please come and destroy me. And the cytotoxic T cells destroy the cell, which is the factory for viruses. And this is an important part of the immune response. Of course, our vaccines that only make immune responses to spike, the question is, if we get changes in the spike gene, will the vaccine still work? So the next slide then is, are there changes in the spike gene? And of course, yes, there are, and there are very, very many. So here we've just lined up Delta and Omicron, the two most recent variants. And you can see, and this is a zoom in of spike. So this is a sort of linear diagram of the spike gene, and you can see these different numbers referring to mutations and deletions that occur in the Delta spike. And then you can see in comparison down here, Omicron, with so many more amino acid changes, changing the way that spike looks to our immune system. And particularly here in this dark orange patch, which is a really important part of spike, which is known as the receptor binding domain, the part which actually latches the virus onto the host cell. You see all of these mutations. We had to amplify up the sort of size of the bars here so you could actually see them, because there are so many crammed in to that place. And you can see that illustrated on the three-dimensional renderings. So here's Delta with its sort of handful of mutations. And then here is Omicron with 32 different mutations across spike. So genetically speaking, Omicron is the most mutated virus that we have seen. And the number of mutations, particularly up here at the tip of spike, at the place where the virus attaches onto host cells, but also the place where most of the antibodies that we make in our immune response target the virus. This now changes the shape of the spike and changes the appearance of the spike to the immune system profoundly. There are other changes going on other than the ones immediately about antibodies. I just put this in to just show this gradual change from what we call the wild type through alpha, delta, Omicron, just zooming in on one little part of spike, just seeing how gradually, bit by bit, the virus is evolving to the human host. And then, of course, there are lots of other changes in Omicron and in Delta compared to the starting virus outside of spike. And actually, as virologists, we're largely ignorant so far of what these all mean. So I've listed them here so you can see that we know that they're there, but we don't really understand what these different mutations do. Do they make the virus more severe or less? Do they help it transmit better? Do they help it evade other parts of our immune system? Do they make it more robust in the environment? We don't know any of those things. We can see these ones that I've highlighted here sometimes crop up in other variants that we've heard about. NSP6, this deletion, we don't know what it does, but it's there in alpha as well and in beta. So we think that this convergent evolution is the virus adapting to the new host and getting better at being a human virus than an animal virus. But as I say, I can't comment on those today, and they're not going to be affecting the vaccine directly. Very briefly, this virus is so very, very different that lots of speculation out there about where it's come from. There are several hypotheses, but probably the most likely is that it's come from a chronically infected individual that has gradually accumulated within that single host this whole array of changes and then transmitted on to other people. The severity, I was asked to comment on severity. I'm afraid I'm going to say there isn't enough data so far to be firm or sure about severity at all. Perhaps Christina may have more than me. All we can really see is what's coming out of South Africa at the moment. And of course, you know, this Financial Times analysis reports increased hospitalizations going up very, very steeply as the Omicron wave was beginning to be seen in South Africa. But we have heard also on various calls that those hospital stays are short, suggesting that people are not staying in with severe illness, and the ITU occupancy may be lower. And I think we have to bear in mind that the demography in South Africa is very different to the UK, much more young people, and also their experience of the virus is very different than ours. They have a high seropositivity rate from previous infection, but rather low vaccine coverage. So making analogies by what we can see in South Africa is really quite difficult at the moment. What I can speak to is a whole bunch of data that's come around from very many labs around the world now. I think there are probably 7 or 8 independent reports, all of which say the same thing, that these mutations that we see on the spike of Omicron mean that the antibodies that are in the blood of people who've received vaccine don't see the virus as well as they did when it was not mutated. And you can see here one example of that from a South African group. They see a 40-fold decrease in the ability of antibodies taken from people who've received the vaccine in these orange dots, or people who've received the vaccine and been infected in the green dots. But you can see that regardless of that background, the slope down between the wild type virus, the starting virus, and Omicron is a 40-fold slope downwards. But people who've been infected and vaccinated have overall higher amounts of antibody, and their end level against Omicron remains above the dotted line, above the level of detection. So there is still antibody there in that group of people who've been both infected and vaccinated. There are drugs out there, for example, Regeneron, or the mixture of monoclonals. Unfortunately, that particular mixture, which we could have used in the UK, would now appear to be rather useless to us, because this flat red line here indicates that both components in that drug just don't see Omicron at all, whereas they did see Delta, which is the grey line at the top here. And how do we interpret those fall off in the neutralizing antibody? What does that mean for how the vaccines will actually work in real life? So those antibody tests are in the lab, but what does it mean in real life? Well, I'll show you some real world data, but there's a sort of, equation graph that was published by this group, where it says that as your neutralizing antibody titer decreases, so does the protective efficacy of your vaccine. And that's exactly what we'd expect to happen. And indeed, that is what we're seeing. So this is the data released by UXA in their technical report last Friday. And what they're doing here is comparing the real world vaccine effectiveness, very small numbers so far, only 500 people in the Omicron arm, but they're comparing how well do our vaccines work against Omicron versus how well they work against Delta. And that, of course, varies with time since you received your second dose. So what you see in the black squares here is the waning of antibody effectiveness or vaccine effectiveness rather over time against Delta. And then you see this is where we come in with Omicron. And unfortunately, this is the 0. So at the moment, Omicron for people with 2 doses is 0% more or less. After 2 weeks after a third booster dose, it comes back up to around about 70%. Now, this is the vaccine effectiveness against symptomatic disease. So this is not scoring against hospitalization or death. It's about counting how many people in our community are testing positive with confirmed symptomatic COVID. Here you can see this was AZ and this was Pfizer. So 2 doses of AstraZeneca followed by a Pfizer booster, 2 doses of Pfizer followed by a Pfizer booster. Even in 2 doses of Pfizer, you see you fall down against Omicron to below 40%, but you come back up again to nearly 80% after the boost. This data has just been released by the South African Medical Research Council. I think Christina will probably be able to touch on this kind of thing better for me, but it did suggest in their vaccine effectiveness that 2 doses of Pfizer is providing 70% protection against severe complications. Now, in comparison, it's difficult to know what they mean and how they've defined severe, but we would normally expect 2 doses of Pfizer to provide nearly 90 or 95% protection against a Delta-like virus against severe disease. So that suggests that even for severe disease, there is probably a fall off in the vaccine protection against Omicron. And I'm just going to finish with a couple of thoughts. So I think what I can definitely conclude is that 2 doses of vaccine are not enough to control symptomatic infection with Omicron. Data on severe outcomes is really not yet available. But if you're a person who's been infected and vaccinated, or you've had your 3rd vaccine dose, that raises the antibody titers and the vaccine effectiveness. But what we don't know at the moment is how long does the booster effect last? I'll just show you down here in this bottom right-hand side, a graph from one of the groups which have posted a non-peer reviewed bioarchive paper. You can see in the middle, the second one along is 2 doses of Pfizer followed by a Pfizer boost with half a month or 2 weeks later, you see a definite increase in the number of people that make it above the dotted line. So it goes from 0% up to nearly 60% of people having some antibody. But 3 months after that booster dose, you're back down again to only 25% of the people having that antibody. So we're definitely boosting, but there is some doubt as to how long the booster will last. And finally, I think it is still really an unknown about severe disease. Everybody is relying on the fact that the T cells see parts of the virus which have not necessarily changed in Omicron, and therefore the T cell response, which we believe contributes to protection against severe disease, hospitalization and death, may remain somewhat intact against Omicron. That's what we don't yet know.
Thank you so much, Wendy. That's really very, very helpful. And I've got a million questions, but we just don't have time. So we're going to go straight on, if it's all right, to Christina. Christina, over to you.
Hi. So, how do I share? Here we go. PowerPoint. Trying to think how. Okay, I'll share this. So can you see that now, my PowerPoint?
Yes, go ahead.
Yes, okay, good. Right, so I'm just going to give you a kind of a whistle-stop tour of where we are with Omicron in the world. I'm just going to concentrate first on South Africa, then Denmark, and then finish with the UK. So I think it's just worth highlighting that we first heard about Omicron less than 3 weeks ago. It was 3 weeks ago tomorrow that there was this first warning. There'd been only 6 cases at that point identified in South Africa and 1 in Botswana. Within 2 days, everyone who was looking at it was saying it's the most worrying variant we've seen, and the WHO classified it as a variant of concern that day. So we're so early in this wave still. And 3 weeks ago, this is where South Africa was. They were just starting to see an increase in cases after really very, very low levels for several months. That's where they are today. They've reached an all-time high and they're still going up. There's been some confusion because they were reporting problems this weekend. So there was a big backlog reported on Sunday. it was focused in Gauteng province, which is where Johannesburg and Pretoria are, but it has been spreading outwards. So this is 3 weeks ago, and this is the most recent week. This is recent data from Gauteng province with data up to the 8th of December, so the end of last week, middle of last week. Blue is admissions, cases in each of the now 4 waves. Yellow is hospital admissions, and red is deaths. And they've kind of been normalized, so they're all kind of at roughly the same time and scale. So what you can see is that compared to the previous waves, there are far fewer hospitalizations and deaths recorded so far for this wave. But this is very likely because South Africa now has a lot of previous immunity, both from really high levels of previous infection, so 60 to 70% of people might have had it, and they've got about 25% of people vaccinated, and that's skewed towards the older and more vulnerable population. So this is, in a sense, the pattern that we saw in spring when Delta came compared to January when Alpha came. So we've seen far fewer admissions and deaths with Delta than we would have done without the vaccine and previous immunity. Deaths take 2 to 3 weeks from infection. So even in South Africa, they're only just starting to increase that. We will not see it in the UK for several weeks. It's too early to look at deaths. Now, Wendy said a lot of this already, but it makes it really hard to transfer what's happening in South Africa to the UK context. They are a younger population in general, much younger than the UK, and also the people who've got Omicron in South Africa have been skewed towards younger people, so much less likely to need hospital or die. Population's much less vaccinated, but higher previous infection. But one of their big waves was Beta. They haven't had an Alpha wave, and we don't know how that will affect things. Wendy might be able to say more about that. It's the middle of their summer, and it's the middle of our winter. We know that its transmission is much worse in winter. And just in terms of deaths, that their death reporting is a bit more lagged than the UK as well. Wendy already covered this in the data that came out today, indicating that there is slightly lower severity of Omicron versus the first type, the wild type of COVID. But there is a big hit in vaccine efficacy. So they've shown that efficacy of two Pfizer doses was 80% against infection against Delta, and it's dropped to 33% against Omicron. That's very similar to what UKHSA reported last week. But what's more concerning, and again, Wendy mentioned this, is that the effectiveness against hospitalization has gone from 93% to 70%. So it's good, but that's a lot more people who are at risk of hospitalizations than we had before. And the other worrying thing is that it looks like children might be at higher risk of hospitalization during Omicron, and they're not vaccinated. So in terms of kind of a more comparable population and vaccination state, Denmark is the place to look. It's the country that probably has the best sequencing in the world. They're seeing 2-day doubling of Omicron cases there. They basically sequence almost every positive case in Denmark, and they have excellent testing. So this is the actual data up to last Thursday. So it was going very rapidly from 0% to over 12% of cases. The Danish authorities released this yesterday, or the 12th of December, of their projections. This is Omicron, and you can see that they felt Omicron would be dominant in Denmark today or tomorrow. And this is on top of a Delta wave that was already causing problems in Denmark. And here you can see where Denmark is. I mean, the cases are shooting up. Most of this is Delta. Only the last few days it will be Omicron. So this is really before you've seen the impact of Omicron, that the really rapid growth that you see in Omicron cases becomes all cases once it's dominant. And so things get worse before they get better. Denmark also yesterday published its updates on Omicron cases by vaccination status, which is kind of good to see. So about 77% of the Danish population is fully vaccinated, compared to just under 70% in the UK. But they have only 22% boosted, whereas we've got 35% of people boosted. But you can see when it comes to proportion of Omicron cases in each of these categories, that fully vaccinated 2-dose people is 75% of their Omicron cases, and 9% of their cases have their booster. So this suggests that actually there's some protection against infection, but it's not perfect, even if you're boosted. So, and I think this is also very consistent with what UKHSA reported. In terms of who it is, by far the biggest age group that has Omicron is the 20 to 29-year-olds, and this is most likely reflected to basically going out just before Christmas and hospitality. And we know that there have been several reported super spreader events in hospitality, and at the beginning of any wave, if you get super spreader events, they have a disproportionate impact on growth. And I think that is what we're seeing across the world at the moment. The other thing that they're reporting is hospitalizations in Denmark, and this is a bit less happy. So it's very, very small numbers. So they've only had 28 people in hospital with Omicron so far, out of 3,500 confirmed cases, but that's 0.8% of confirmed cases. And this is in a younger population than general in Denmark. And that compares to 0.7% hospitalized with Delta. So it's around the same. So they're not seeing reduced hospitalizations at the moment in Denmark compared to Delta. Now, as I said, this is very small numbers. It's very preliminary, but it does kind of mean that you can't say for sure that it's going to be milder. So going on to the UK now, this is the proportion of sequence positive PCR tests that are Omicron by UK nation to the week ending 11th of December, so to last week. This is from COG UK, who do the genomic sequencing. The most recent data is still very incomplete, but the proportions should be roughly accurate. And you can see that it's highest in Scotland, almost 20%. This is up to the 11th of December. And 10% in England, and much, much smaller in Wales and Northern Ireland, although it is starting to grow there now in both of those nations. From UKHSA, from their tech report last Friday, which was 130 confirmed cases, this is sequencing data in England. Again, it's most prevalent in the 20 to 29-year-olds, just as we saw in Denmark, and as we also have seen in Gauteng in South Africa. Now, you can also look at Omicron by what's called the S gene dropout. So for some types of tests, you test for 3 genes for COVID, and one of them is called the S gene. And Omicron has this feature that it doesn't show up on the S gene. So it's called an S gene dropout, whereas Delta does. So you can track it that way. You don't have to sequence it. And now almost all of S gene dropouts are Omicron, because there are other variants that do it, but they're now almost all Omicron. So it's a really good way of tracking it much more quickly than sequencing. And this is the proportion of cases, this black line in the UK that have this, and this is over 20% now. And this is up to, I think, the 12th, data up to the 12th of December. In terms of absolute numbers, the most recent days are very complete, but again, the proportion is telling you something. And compared to last Friday, when we had 130 confirmed cases, we now have 4,000, almost 4,500 confirmed cases in England. So things are moving very, very fast. Regionally, you can see this S gene dropout signal is growing rapidly in every single region. So basically everywhere is going to have Omicron dominant within a week or two. In London, it's the highest. It's 44% of London cases as of the 11th of December. So it's very likely that it's already dominant by now. And I think the other regions may be a few days to a week behind London, but we can expect cases in London to start really going up very fast as of now. And if we look at regional cases, this is confirmed cases in England per 100,000 people up to the 9th of December, because you have to have a bit of a lag if you're looking at date of test. This is London, is this blue line, and you can see it has started going up. It was already going up, and now it's starting to go up even faster. And that's reflected as well in the proportion testing positive. So it's not about differences in testing at all. So London was going up a lot over November. This is Delta increasing. We haven't finished our Delta wave. And then the most recent really sharp spike here is likely an Omicron increase. And unfortunately in London, it's kind of a bad place for this to be happening. This is hospital admissions by region. And London has been one of the lowest regions for pretty much all the summer and autumn. But over the last few weeks, it's been rapidly increasing, and it's now the highest region of hospitalizations. Most of this is Delta, and the Omicron effect hasn't come on this yet. And what you're seeing, if you look at age groups in London, is this really steep increase in 20, 29-year-olds just in the last few days. Still very high cases in school-age children, but they're starting to come down. And the other big increase is adults 30 to 59 who are just now getting boosted. And we've also seen an increase in over 60s. And that is concerning. Remember, London is by far the least vaccinated region in England. Now, what will happen? So currently, to date, Omicron's been doubling every 2 days in Denmark and South Africa and here. It started maybe, towards the end of December. Exponential growth goes quite fast. We're now at about here, 13th to 14th of December. It's about 10 to 15,000 new Omicron cases a day, on top of about 45,000 Delta cases. So that gets you to about 55K, which is what we're seeing. But it will now rapidly go up. And if it carries on, you get to several 100,000 cases of Omicron within a couple of weeks. And that's kind of the scary numbers that have been floating around, like in Parliament yesterday. Now, it's not unreasonable to expect growth to slow, right? It's hard to sustain that level of doubling in any population. Plus, we're having more measures coming in, schools are breaking up, people are starting to go home for Christmas, and people are starting to behave more cautiously anyway because of all of this news. So I think you won't see this growth sustained, but there will still be growth. And there's absolutely no doubt that we're in for a really rapid increase in cases over the next few weeks. It doesn't have to get to here to be problematic. It only has to get to here to be problematic, really, in the UK. And just remember that our testing capacity cannot test that many people. So we will start to see testing falling over the next few weeks as well. So just last slide. Given that we are going to see a massive increase in cases, just as Wendy said, what's absolutely key is, will our immunity wall hold against Omicron? And unfortunately, I think we're going to find out. This is the graph from John Ben Murdoch, which uses data from UKHSA and the Cambridge MRC unit, of kind of the status of the English population by immunity. So there are very few people who've neither had a vaccine nor been infected. Those are your completely kind of naive, immunonaive people. This is all over 15s. You have actually quite a few people still who are on one dose or have only just been infected. And then a lot of people who are still on 2 doses. Those are the people waiting for their booster. And then really you have kind of the best type of immunity, either people who've had 2 doses and been infected or had their booster, or best of all, well, from an immunity point of view, not necessarily from a public health point of view, have had 3 doses and been infected. So the darker colours should have quite good protection against severe disease. The lighter colours, less so. And exactly how much less so is what's going to determine what happens to the NHS over the next 4 to 6 weeks. And we just don't know yet. And that's the kind of really frustrating thing. But I think whatever happens, it will be worse than if Omicron hadn't come. Absolutely. We're going to get a lot more infections, and the vaccines just don't work as well against it, even if they still have good efficacy against hospitalizations. And finally, we can't forget about children. There are indications that it's more severe for children. Children at best have 1 vaccine dose. Millions of them have none. We know that Delta ripped through schools this term, and we have to, you have to expect that unfortunately Omicron is going to do the same if we don't do something about protecting schools in January. And I will end there.
Thank you so much, Christina. Again, a million questions, no time. Straight over to Stephen.
Okay, so let's see if I can get this to work. Right, can you see that? Yeah?
Yes, please.
Good. Okay, so I'm going to do my presentation in a slightly different way. I was asked 4 questions, and being very obedient, I've answered all 4 questions directly. So each of my slide addresses one of those questions. It feels like being back at school and doing my exams again. So we'll see whether I pass or not. Okay. The first question was, and it's a question that the media ask all the time, how willing will people be to abide by the new rules? Now, this is a question which is asked all the time, and often there's a hidden premise to it, which is that the problem in the pandemic response is the public, that the government and authorities would like to bring in measures, but they don't know if they can, because will the public wear it or not? And I think that's a misrepresentation of what's been happening throughout the pandemic. In fact, if you look at the polling data throughout the pandemic, first of all, people have been calling for measures before the government has, and they've been more reticent when measures have been lifted. Certainly, if you look at the recent polling, even back in October, the majority of people supported all the measures in Plan B. They supported measures like masks in public places. They supported vaccine passports. They supported working from home. And what's more, a substantial proportion of them, about a third, supported further restrictions, including restrictions on the opening of venues and and on public mixing. It was a minority, but it wasn't an insignificant minority. And remember, that was even before we'd heard of Omicron. So the public, in many ways, were more aligned with SAGE than the government were aligned with SAGE, because remember, back in September, SAGE was calling for such measures, as were a whole series of other bodies, including the BMA, the NHS Federation, various royal colleges, Macmillan Cancer, and so on. So I think if you're talking about motivation, the notion that motivation is a problem, I think, is a misreading of what's been going on in the pandemic. As I say, on the whole, the public have been following the science, and as they see the risk going up, they change their own behaviours and they are more in favour of measures being taken. However, and this is very important, however, behaviour is not just about motivation. It's not just what I want to do. And increasingly through the pandemic, it's become clear that 2 other factors are as important, if not more important than motivation. The first is information. To do the things we need to do, we need to know what they are, and we need to know what the problems are, and we need to know how to respond. And I will come on to that in a moment. And the second is opportunity. In many ways, that's been the major problem throughout the pandemic. So right at the beginning, there was evidence which showed that poorer people and minorities were 6 times as likely, between 3 and 6 times as likely to break break lockdown as more affluent people. Had nothing to do with motivation. Motivation was identical. It was almost entirely to do with the opportunity to stay at home and put food on the table. So I think in terms of behavior, I think the focus on motivation is misleading. And we need to put much more focus on information and on opportunity. I will come on to those, as I say, in a moment. So, is the present government guidance consistent? Well, as exam questions go, that's probably the easiest I've been asked in a very long time, because the answer is no, 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 and no again. So what are those 4 no's? Well, right again, early on in the pandemic, one of the points that Spy B made very strongly was that any information, any messaging, any advice has got to be specific, so that when you read it, you know precisely what to do. And if you don't know what to do after you've seen the messaging is basically useless. And when there was a change from stay at home to stay alert, we were deeply concerned. And in fact, we wrote a paper to express our concerns in the messaging, because stay at home is reasonably clear. It means stay at home. 96% of people understood that. Don't know what the other 4% were thinking, but no polls give you 100%. Only 31% understood stay alert, because how do you stay alert to a virus? What do you do? And at the moment, we are being told things like, be careful, socialize carefully, party carefully. Well, again, what does that mean in practice? What should I actually do? That information is useless to me. So the first thing about the government messaging and guidance is it repeats the mistakes of the shift from stay at home to stay alert. Secondly, it's contradictory. Many people have pointed this out. So, we are told, stay at home during the day, but do go out and party at night. Those contradictions are very clear. And of course, again, they are very toxic, because it means, again, it's confusing. You don't know what to think. You don't understand the logic. It seems arbitrary. Why should you do it? The reasons for doing it aren't clear. The third, and again, I'll come on to this in a moment, and it's the thing that has been in the headlines for a long time now, words and actions are contradictory. If you tell people to do one thing, but you do a different thing, it's a problem. But the fourth thing, which I think is equally important, is words and policies are contradictory. Now, that was very clear early on when it came to mask wearing. There were various exhortations as we began to learn about aerosol transmission and the importance of masks, that people should wear masks. But basically, the level of mask wearing stayed stubbornly around 20%, because many people were saying, look, if it's that important, it would be made mandatory. And if it's not made mandatory, it can't be that serious. As soon as it was made mandatory, despite all the fears, mask wearing in a couple of weeks went from about 20% to about 70 or 80%. So remember, policies are communications. The notion that you have a policy and then you have communication, I think, is a false dichotomy. One of the most powerful forms of communication is policy. And to tell us that right now we are in a crisis, and to tell us a tsunami is coming at us, but at the same time, actually to have weaker measures than were proposed by SAGE in September before Omicron came along, is a contradictory message. It says it's not that important. Right. What is the effect of government rule breaking? Well, I have taken the opportunity, shamelessly, to advertise our book on leadership, because in many ways, what has happened violates the basic rules of leadership. Leadership, the ability to influence others, it's probably the first rule of social influence, stems from a sense that the source of information is part of us, is one of us, is part of the community, is, using the technical language, is in-group. And therefore, if the government does different things to that which it tells us to do, it creates a sense of us and them. They become out-group, they become other. And even worse, if they are seen to have contempt for us, and that was the effect of the infamous video, it creates not only a division, but an opposition between government and the people. They have contempt for us. And all the evidence suggests that leads to a loss of trust and a loss of influence, and it becomes a warrant for rule breaking, and it becomes a government unable to lead. That's precisely what happened post Cummings. So the polling, this was work by Daisy Fancourt, and it showed very clearly that after the Cummings affair, the level of trust in the UK government, not ScotGov, not the Welsh government, but in the UK government, fell precipitously from around 70% to around 20%. And a lot of people began to use that as a warrant for rule breaking. The police reported that many people on being stopped would say, well, why can't I do it if Cummings did it? It undermined the government's ability to lead. However, and this is an important but, actually when you looked at adherence wasn't that much affected. So if you looked at the levels of adherence to, say, mask wearing and various other things when the rules were the same in Scotland and England, despite the fact that levels of trust were night and day, adherence wasn't that different. And the reason why is that people were in many ways adhering despite the government. People were listening to the science and taking from the scientists, and there's still a very high trust in the NHS and in science, around 80% and more. They were listening to them. From that, they got their sense of risk. And people were also listening to each other. Social norms about how to behave were really important. So I think it's important not to underestimate the importance of government rule breaking. It means in the end, they can't do their job. They can't lead us through a crisis. But equally, it's important not to overstate it. There is a rather dim silver lining, which is that people themselves are still largely adhering, but despite the government. Let me come to the final question, the effects of vaccine passports. Now, this is a complex one, and I think it's one of those things where people want to make it simply one way or the other, when in fact the evidence is more nuanced. So it has different effects on different populations, and therefore it has different effects in different places where the nature of the populations differ. So just today, there is a paper out in Lancet Public Health, a big study from Oxford, which shows that in many low vaccine uptake countries, the introduction of vaccine passports increased vaccination. And in fact, that's what you find in most places. If you think of those who are not vaccinated in terms of different groupings, so the vaccine indifferent, they're not anti-vaccines, they've got nothing against vaccines, they just don't think they're that important. They haven't got round to it. Now, when you give them a reason to be motivated, they do get vaccinated. So you increase the level of vaccination in that population. However, for those who already have doubts about vaccination, and for those who have fears that they might not be being imposed for their own good, but being done to them to control them, then vaccine passports has the opposite effect. And in our own data, we find that amongst those populations of low trust, vaccine passports alienate people, and they feed into the hands of the anti-vaxxers. They validate their narrative that vaccination is about control. And if you look at the populations where there is low vaccination, they are, of course, those populations which have a history of low trust in authority. They are unemployed people, they are deprived people, they are ethnic minorities, and so on. So the real danger is you polarize. Yes, you might get a short-term boost, but you consolidate a group of people who are going to be more negative, who are going to be more influenced by anti-vaxxers, and who may well be more recalcitrant if we need to have future vaccination. And while, as we heard earlier, we can't be sure, there's a pretty good chance that we not only will need boosters, but might need, if you like, boosters to the boosters in due course. And if you create those populations, then that's an extremely negative thing to do. And of course, if you polarize society and you create social division, you undermine one of the key things which is positive in terms of the pandemic response, which is a sense of community. So the real question then, I think, is can one find other ways to increase uptake without the negative side effects, especially in those communities which are reticent. And in fact, the authors of the Oxford paper make very clear that their own data doesn't speak to that. Their own data doesn't analyze by, for instance, gender or by ethnicity, and that actually much more down-to-earth methods like community engagement. In other words, if the problem is trust, and not trusting people, then the main thing you've got to do is to build trust. And you build trust not by speaking about to those who haven't been vaccinated as if they are stupid or selfish, which has occasionally been done by government figures. Rather, you take seriously their concerns, you listen to those concerns, you talk to people, and so on. Let me make one final point before I finish. And that is to go back to something that I said at the beginning about public behavior. I've talked at length, probably too long, I apologize, about the importance of information. But I also mentioned the importance of opportunity. Now, it seems to me that two key elements in our response to Omicron have got to be testing, people testing themselves to make sure they're not infected before they go and meet others. It's not perfect, of course. We know that LFTs shouldn't be treated as green light tests, but still it's an added protection. That testing is critical. And number two, that self-isolation is utterly critical. When people are infected, it's absolutely essential that they and their close contacts do self-isolate. But we also know that, number one, there has been real problems in self-isolation because people couldn't afford to do it. And secondly, right from the start of mass testing in Liverpool, that poorer groups didn't get tested because they couldn't afford to find out they were positive, because they couldn't then afford to self-isolate. And so it does seem to me that if you are talking about these things, testing and self-isolation as key elements in our response to Omicron, it becomes equally important to address a question which has been a question throughout the pandemic, never really been dealt with, is to give people the opportunity to do so by giving them support, by making that support adequate, by making it comprehensive and making it easy to get. And it seems to me clear information and clear support, and it relates specifically to that question of self-isolation, but there are other forms of support that are necessary. Those are the two things that absolutely need to be put in place if you want people to act in the ways that they need to act to slow down the infections and to avoid the dangers of society and the NHS being overwhelmed.
Thank you so much, Stephen, and thank you so much to you all. We have run over, but absolutely you are forgiven for running over and giving us such data-rich and opinion-rich presentations. We've just got time for one question from Barbara Keeley. Barbara.
Thanks, Chair. Could I ask each of the panelists, what is your key message recommendation to the UK government? Wendy, shall I start with you? Thank you. Professor Wendy.
Yes, I mean, I would say that getting booster vaccines out, I think is the right course, but I think Christina raised an important issue about children. So I think we need to be considering how to protect children. And then, as I sort of intimated, the boosters are a good way to go. It's really, I think, our only choice at the moment, but I think we need careful monitoring of those who've received their boosters some while ago to make sure that we think the boosters are going to keep lasting, to keep doing what they do. I have confidence that we have systems in place to do that, but I need government to give support to UK HSA, who are doing a fantastic job, to keep monitoring that is the case, so that we can respond if it turns out not to be.
Thank you. And Professor Christina Pagel?
Well, I agree with everything Wendy said, but I would say that we have to get transmission down now, because even if you reduce growth by, a factor of 2, even if it still grows, if you can slow it down because of exponentials, you get far fewer cases. And because, as I'm sure you'll hear later, the NHS is already at breaking point. We just can't afford to add to it. We're not in South Africa, where they started their wave from very, very low cases. We've had really high cases for months. So we have to get transmission down. So I think it has to be limiting contacts, and how you limit contacts. There are lots of different ways of doing it. Do you just tell people no Christmas parties? Do you put actual numbers on number of people who can go out? Do you start thinking about closing larger events or so on? I don't know, but that's what we have to do. And I think we can't wait to see the impact on the NHS, because if this thing's moving too fast.
Thank you. And Stephen?
So I'd entirely echo what Christina says. I mean, we need to get cases down now, because while we all agree we need to get boosters, number one, it will take a number of weeks to give people those boosters. And number two, it will take a couple of weeks for the effects of those boosters to kick in. And if we were to do nothing now, by then the cases would be catastrophically high. So we need to bring cases down in order to give us time to vaccinate. Now, the simplest metric of the whole pandemic is that the rate of infection depends upon our rate of contacts. If we have more contacts, there's going to be more infection. So the simple message is we've got to reduce contacts. Before the pandemic, they were at about 12 a day. We would meet about 12 contacts a day. At the height of restrictions, they went down to 3. They've gone up to 5, perhaps even a little bit higher now. So we've got to bring them down. And there are 2 ways you can bring them down. You can bring them down by giving very clear advice, which is don't socialize. If you do socialize, now you won't be able to socialize at Christmas, and you need to be clear and consistent about that. Or you can limit socialization by legislation. Now, that's a very real debate, but it seems to me that's the only debate that should be being had right now, not whether, but how we bring down the level of contact. I'd say just one final thing, if I may, and that is that one of the problems in the past with restrictions hasn't been so much imposing them as lifting them, because if you do nothing to change things, when you lift restrictions, then infections will simply go up again. So you've got to use the time where you have restrictions to do something else. Now, boosters is one thing, but I think it is equally important that we make our environments safer so people are less likely to get infected. So use the time, for instance, to make sure we bring in ventilation into schools and to public spaces. If we do have restrictions, without using the time, not only for infections, but to that wider making the environment safe, then again, I think we will have squandered the time and squandered the effect that those restrictions have at a great cost.
Thank you.
Thank you so much, all of you. Thank you, Barbara. We are now going to move on slightly late to the second panel. I thank them as they are incredibly busy people for their patience with us. And if I may introduce them in just a moment, we wanted as a all-party group to put on our record, given that our panel represents industry bodies from many frontline NHS workers, our thanks to the NHS and all those who work in it, also the volunteers and also local authorities and anyone involved in trying to keep this pandemic at bay. They are being asked to go above and beyond. They are at breaking points. We recognize this, and wholeheartedly, we wanted to put on record our sincere thanks to them, and recognizing that thanks is not enough and what they need is support. Our promise to them is, off the back of this evidence and everything else we've heard, we will continue to advocate for more support to them. And we wanted to just simply put that on the record at the beginning of the session today. If I could now welcome the next panel, and we have a huge amount to cover, and I will try our very best to keep us to time. Thank you so much for joining us, Chris Hobson from NHS Providers. Chris is Chief Executive of NHS Providers, the membership organisation for 217 acute community mental health and ambulance trusts and foundation trusts. We also have with us Dr. Catherine Henderson from the Royal College of Emergency Medicine. Catherine is President of the Royal College of Emergency Medicine and has been an emergency medicine clinician for over 20 years. Welcome also to Dr. Chand Nagpal from the British Medical Association. Chand is a GP and senior partner in a practice in Stanmore in North London, and he was elected as chair of the BMA Council in July 2017 and has been a council member since 2008. And we also have with us Elaine Thorpe. Elaine is an ICU matron on critical care at the University College London Hospitals NHS Foundation Trust. Thank you all for being with us. And I'll start with a fairly meaty question, which is simply, given the rise in the number of daily COVID cases, could you just give us a brief sense of, from your perspective, where are we now? And also, could you also give us a sense of how sick are the people that you and your colleagues are seeing? Because that seems to be the top question that we've been being asked, and we would be very grateful for your sense of that. Perhaps if I could start with Catherine.
So thank you very much indeed. It's a pleasure to be here. So at the moment, the situation in the emergency departments and our interface with the ambulance service is extremely pressured, but it's not necessarily more pressured with sick patients in relation to Omicron yet. You know, that hasn't worked its way through to hospital admissions yet, but it's only a matter of time. But what is affecting us more is staff having to be off who are positive with COVID. So we're seeing significant pressure on our staffing, in addition to the pressures that we've already got because Omicron seems to be so transmissible. And so you get whole families taken out. And we're seeing regular gaps in rotas in all aspects of our teams in hospital, and I'm sure in ambulance services and in primary care, because people are testing positive, which means that a pressured situation has become a really pressured situation. And then the expectation is that we will start getting both Delta and Omicron patients who are unvaccinated getting infected, and them being the ones who then are the sickest and are coming in. And we're still seeing plenty of, in the emergency department, we don't know whether somebody's got Omicron or Delta. You could have a bit of a guess if it's a member of staff because of the transmissibility, but an individual patient, we won't know at that point, and obviously has to be tested later. But we're not seeing a sudden wave of more sick than they were before people, certainly. And we're still seeing individuals who are really sick, but they tend to be unvaccinated patients.
Thank you. That's very helpful. Chan?
Sorry, good morning. You can hear me all right? Okay, right. Yeah, thank you very much for giving the opportunity. And I'm speaking, of course, on behalf of doctors working in primary care, secondary care, public health. We represent all categories of doctors. I think the first thing to say is that the health service is overstretched, and it has been overstretched for a while, and it hasn't needed Omicron to highlight this problem. You will have been aware over recent weeks that overall bed occupancy is above those that are considered safe across the nation. You'll be aware of the long ambulance queues that have been a pitiful sight that should not be part of our health service, but that's actually a reality in many hospitals, and patients even dying whilst ambulances are waiting outside hospital. You will be aware also of critical incidents in recent days, like in Portsmouth, I think only yesterday, and also patients having to be transferred from one hospital to the other because they're full. So we have a system that is under huge pressure, and let us not forget that there are also about nearly 6 million patients waiting for treatment, and the 12-month waits have gone up to about 312,000. So there's serious illness that isn't being addressed, and patients aren't being treated. Now, on top of that, we have a real problem with workforce. We started the pandemic, unfortunately, on the back of 10 years of lack of resourcing, with around 50,000 doctors short compared to other nations like France and Germany. And what's happened over the pandemic is, of course, as demand has increased, we haven't been able to meet that demand. At the moment, what our members are saying, and our surveys are showing, is that doctors are absolutely exhausted physically and emotionally. All healthcare workers, as you will know, throughout the pandemic have not worked from home. They've had to go into work throughout each of the lockdowns, and they've had to deal with probably the most grueling and traumatic experiences. And I think sometimes we forget that whilst we're not in the days of March to April of the first wave, the truth is, for many healthcare workers, that trauma continues, and we're seeing a lot of doctors who are actually experiencing delayed emotional trauma, and they are exhausted. 35% tell us that they're suffering with a psychological disorder at the moment, much higher than before the pandemic, and we know about 20% intending to leave the health service in the coming year. That's what they're saying to us. About 50% are saying they want to reduce their hours, not because they don't want to do their jobs, but they feel they simply cannot carry on in this relentless environment. So it's really important that we deal with Omicron, because this is just going to add further pressure on a health service that simply hasn't got any give. But also what we're worried about as a profession is that when we can't be in two places at once, when we can't actually, for example, I'm a GP, we can't carry on business as usual, whilst at the same time, our staff having to now free themselves up for the booster program, and then having to be criticized for somehow not having the access. And when people say, for example, they can't even get through to their GP surgery, I can tell you our phone lines are buzzing, ringing away with patients asking about vaccinations, asking about their delays for hospital appointments, etc. So I think it's really important that we as a profession are valued and understood, and really politicians should be explaining that to the public rather than us take the hit for system pressures, not of our own making.
Thank you very much. Elaine?
Thank you for inviting me to talk here. So I won't go over what's already been said, but when I talk about intensive care, so we're very, very busy. We're nearly at capacity every day in all our intensive care units, not just in my trust, but many other trusts. We've had a COVID ICU in operation for several months now. We have no Omicron admissions yet, but we are really, really worried that this will happen soon. So we have been preparing since every surge for the next surge, and we're having to accelerate that now and probably enact expanding to create more intensive care units. And whilst there's been huge support and investment from our organisation in terms of having enough equipment, the best resources available for staff, our staff are really, really struggling. They are mentally exhausted, physically exhausted, and they haven't processed the moral injury that they did before. And one of the things I worry most about is that when you have to do this, you can't give the care that you want to. So for instance, nurse to patient ratios should be 1-to-1 on intensive care. No nurse, no doctor wants to have to look after more than the number of patients that they should. And they want to do that. They want to do their very best for the patients. But when we go into situations like this, we can't give the care that we want for our patients. Our relatives can't see their loved ones. All these things that we want to do to provide the best care we can do have to go. And that's the bit that you can see it in the eyes of the nurses, the doctors, the physios. They're terrified of having to do that again. I would echo that we've got a problem now with the population acquiring COVID. We've got a lot of staff really going down with COVID, and that's really impacting the number of nurses, doctors, admin staff, everyone behind the scenes. You know, it's not just the staff who work at the cold face in A&E and critical care. It's throughout the NHS that's really going to be impacted on this, and we're really worried.
Thank you very much. Chris?
Well, if you roll back a couple of weeks, when you had the latest statistics, performance statistics published by the NHS, they will have shown that the service was, words we're using is beyond full stretch. So give you 2 or 3 statistics. We were running at 94% bed occupancy compared to 87% at this time last year. In November, we had the largest number of 999 calls we've ever had to deal with in any November. We had the second largest number of people coming into accident and emergency departments. So you had a service that was, as I said, in our view, beyond full stretch. We've been on the record to say that we were very concerned about that, not least because we knew that we were in advance of the traditional January peak. So we know that the NHS tends to get even more busy in the first 2 or 3 weeks of January. I think what's then happened is 2 things have happened since. Obviously, we've had the Omicron variant arriving on our shores. And I think all the evidence we have in front of us suggests that there will be a considerable impact in terms of degree of hospitalizations. And the key point I think to grasp is, irrespective in a sense of the severity of the symptoms, if you have a very large number of people who are infected with Omicron, and we know that this variant is significantly more infectious and more transmissible than Delta, it doesn't take a particularly large percentage of people to be hospitalized before you get a large raw number of hospitalizations. And that, I think, is the concern. And then obviously we had 48 hours ago, the Prime Minister's announcement that he wants to make, and the government wants to make, vaccinations, the absolute booster vaccinations, the absolute kind of priority between now and the end of December. And one would assume longer than that if we're unable to hit that December target. So we were already beyond full stretch before we got to winter. We're now facing the prospect of significant numbers of hospitalizations, probably starting, I would think, in the next week to 2 weeks. And then also the fact that we absolutely need to focus on getting these boosters vaccination take up, which has got to be the top priority for the next 2 to 3, 4 weeks. So add all of that together, and the obvious question is, there is a huge amount of pressure on the service. Could I just say one thing, which is we're always nervous and don't use the phrase breaking point, because the whole point about the NHS effectively is that thanks to the amazing dedication and professionalism of our frontline clinicians like Catherine and Elaine and Chand, is that actually we prioritize. And what happens is we prioritize the most clinically urgent cases. And what happens in that process is patient safety risk increases and quality of care comes under pressure. But I think we try to avoid this concept of suddenly the NHS sort of tipping over or breaking, because actually that doesn't happen. But what happens is that you just get real increasing risk for both staff and for patients. And we think that's a better way of describing the consequences of the degree of pressure that we're seeing.
Thank you very much. And that's very helpful framing. Really appreciate that. Baroness Finlay.
Thank you very much. And thank you. I wanted to ask you, you've partly answered it actually, about how the NHS and staff will cope with greater pressures, but also looking at the best and worst case scenarios. And I'd like you to think about that in the context of stories of staff being on the receiving end of increasing amounts of aggression from angry patient groups, population groups who don't understand why they either have to wait or can't get what they want, or are just angry about their own situation. And with particular framing in terms of children, if we do have a large number of sick children coming forwards, and how prepared those services are. And picking up on Chris's point about running at risk, does that mean that actually we have to do something different, like rather than exclude relatives, have designated relatives to come in to provide some of their personalized care, washing, feeding, support, and so on for people, so that the actual physical burden on the staff is less? And Elaine in particular might have some thoughts about that, because there's a great deal of distress amongst relatives who find that they can't visit. And are we now at the point where excluding them no longer makes sense because of the infection rates? And I think I'd like to go to Catherine, and then Elaine, and then Chand, and lastly, Chris. Thank you.
Right. So, I mean, emergency departments have been have had people who are violent and aggressive towards our staff for pre-pandemic. It's not a new issue for us. And yes, there are some cases where people are getting frustrated about the length of the wait. But to be honest, if you're in a queue outside an emergency department and you can see the ambulances coming up, we can manage that issue. It's deeply depressing, but it's more deeply depressing treating people who are unvaccinated and are really unwell and are needing an ITU bed. It's more depressing seeing people getting completely drunk and ending up in emergency departments because the messaging is not clear enough about how understrained the system is. And it's more depressing having complexity of problems that existed pre-pandemic, which have continued and have not been addressed. So in the greater scale of things, we'll deal with the violence and aggression and carry on. In terms of having relatives in emergency departments, we are enormously short of space. We've increased our footprint, but we're enormously short of space if you are trying to do any reasonable social distancing, because we've always been treated as an area with utterly elastic walls, and we just packed people in and we were never full as such. And so not having relatives in has been essential to us being able to manage the space at all. But we've always allowed relatives where there's a language issue or somebody with dementia, or one person to accompany a child. But what we can't do is the whole family with the one child. And I think the risk in that sort of situation, particularly with Omicron transmission issues, would mean that would just be a crazy thing to do. We would not want to start saying that that would be the way to happen. Whether when it's a long-term patient, that might be a different issue, and you could do some testing. But at the moment, we don't know the infection status of anybody who pitches up at our front door. We may know their vaccination status. If they know, they don't always necessarily quite know what their vaccination status is. And we certainly don't want to start having to have conversations to include or exclude. To have another sort of triage point around vaccination, I think would add to the violence and aggression. So we need to keep it simple, straightforward. Patient comes in, if they have somebody who's absolutely essential to getting the best care that they need, we would bring them in already. So how will staff cope? The biggest challenge to staff at the moment is going to be the numbers going off sick. I was on a shift yesterday, and during my day shift, 4 doctors went off COVID positive. They'd done their lateral flow testing. They turned out positive. They were now doing PCR. Now, I think you were talking about lateral flow testing in the last session. From our point of view, a positive on a lateral flow is translating into positive on PCR. So it's very rare that, in fact, I can't even remember a situation where that's not been the case. And so we need to make sure that lateral flow testing is readily available to staff because of the transmission element of this. Now, nosocomial infection has not usually been staff to patients. It's mostly been patient to patient, but there are, and then staff have infected themselves in coffee rooms. But we need to be doing what we can to make it safe for everybody. We need to be recognized. My biggest worry at the moment is that the vaccination program pulls clinical staff into vaccine centres to deliver vaccinations while reducing the number of staff on the ward. So it's incredibly important that the vaccination centres are able to use the lay staff as much as possible, the non-clinically qualified staff, to deliver this booster program. So maximising use of third sector, all the volunteer organisations, all of that stuff, because if we start having to move nurses into a vaccination program or doctors into a vaccination program, you're using very, very precious staff at the moment who I think will find it very hard to manage.
Yeah,
not sure if that covers all
Catherine,
your questions.
Thank you. I think we need to move on fairly fast. I'm sorry, because we're tight on time. So can I go to Elaine and then to Chand fairly fast?
Yeah, so what would I say is the worst case scenario? The worst case scenario is that something the same happens like in Surge 2, where families can't come on to critical care to see their loved ones, and then we start to see the knock-on effect of that. So I'm pretty sure that most organisations have support networks for families that they can get in contact with their patients and their loved ones. The concept of bringing families into support wards, I just don't think is doable, because they are then at risk of getting COVID. They might bring it into hospital, they might bring it into patients who don't have COVID. So we have to go really cautiously with that, and I don't think that is an option. How are staff? So I think I've mentioned that already. They're worried, and we need to be really do everything we can possibly to make this as easy as possible for them, recognising none of this is easy. So we have leaders who are with us all the time who are asking what we need, whether that's equipment, food and drink. Just providing the basics for staff when they come to work is so important. Staff testing needs to be readily available so that they have confidence that they're not taking it home to their loved ones. So just really listening to staff and doing everything we can to make this as bearable as possible is where we're at.
Thank you, Chand.
I think we have to be honest that we're not going to see, even in a best case scenario, there are going to be really pressures. Even the booster program, if we were to vaccinate every single eligible adult, there are still 11.5 million adults who won't be part of the booster program because they've either been unvaccinated, only had one vaccine, or the second vaccine has been less than 3 months. So we're not, I think, the public need to be, the government needs to explain to the public that even if we were to succeed by the 31st of December, next year is still going to have millions of unvaccinated or unprotected members of the population. So if we are to tackle this, you're going to have some other restrictions or other ways of reducing spread of the virus. You have to have a vaccine plus strategy, and all we're hearing about is the booster program. In terms of the abuse of the healthcare workforce, my plea is to those in government, yourselves, to try and be honest with the public about what's going on. We can't be blamed. I'm in a GP practice when we've had a doctor call in sick today, or rather isolating, and you have to cancel surgeries. Patients get upset. I understand that. But they need to understand it's not of our making. And therefore, the messaging from the top needs to be supportive of us. And then I think the abuse may reduce. The other thing about patients actually mixing or going to hospital or even healthcare settings, the government needs to go back to better infection control measures in hospitals. They relaxed the rules only recently. And the second thing is the quality of masks. We know, and our view at the BMA is that the public, and especially those who are vulnerable, should be provided and be wearing FFP2 masks. They're readily available, 95% filtration. They will protect the wearer. And that's quite the norm in some other parts of the world. So it's not only a case of patients not being able to, or visitors not coming in to hospital, it's also how they are protecting themselves and others. That's equally important.
Lovely.
Sorry, Chris, only one sentence, if there is one to add on, really, perhaps over the messaging to the public, picking up on Chand.
I'll pass, given the time.
Good. Thank you.
Thank you so much. And I really do appreciate just the time pressure that we're under. So short, sharp questions and short, sharp answers, please. Caroline Lucas.
Thank you very much, Chair. I wanted to pick up on the issue of pressures on staffing and link that to the vote that we have this afternoon on mandatory vaccination for NHS staff. And my question is, obviously, clearly we all want staff to be vaccinated, but do you have concerns about whether or not making it mandatory would be effective? Does that risk entrenching opposition to it? And if that were the case, is there any concern that, just as we saw in social care, we could actually see NHS staff leaving as a result of that? And maybe I'll come to Elaine first.
So I believe that vaccination is so important, but for myself, I'm at a situation right now where supporting and understanding and providing staff with the right information about what their hesitancy is and how we can inform them to have the vaccine. I don't want anybody to lose their job. So I personally am supporting at the moment.
Sorry, I didn't quite understand that. So you don't want people to lose their job. So you are supporting mandatory vaccination?
I am supporting mandatory vaccination.
Thank you. Anyone else?
Yeah.
Thank you.
After you, Chand.
Yeah, so for the medical profession, the doctors I represent, actually the coverage of vaccinations is very, very, very high. So the proportion that will be affected is small. But of course, we need to now talk about mandatory vaccinations, not in terms of 2 vaccinations, but the booster. But I think what's missing here is this belief that somehow mandatory vaccinations is the all-protecting measure to protect patients, whilst you've got incoherence in government policy. So if a patient is in hospital and might be protected because others have been vaccinated, when they step out of the hospital and go on a bus or go back into public settings, if you don't have the same measures of protection, then you've missed the point. And the second diversion around mandatory vaccinations is there are many, many other things that need to be also done right in hospital to prevent transmission between staff to other staff, staff to patients, and patients to patients. So having mandatory vaccinations and having, reducing the physical distancing requirement to 1 meter, for example, or not having the right masks that we as healthcare workers are calling for, which is FFP2 or FFP3 masks, means that there are other ways that the infection can spread in hospitals that isn't being addressed. So I think it's a message that's just too, it's too selective, instead of looking at the total measures we need to prevent transmission in healthcare settings.
Chris?
So I think life gets complicated when you start to have to judge between competing rights, and clearly patients have a right to be treated by clinicians who they know have been fully vaccinated. Equally, though, there are significant numbers of our staff who feel very strongly they have a right to determine about whether they should have the vaccine or not. And it's therefore quite a difficult issue The government has made its view very clear. The policy is out there. We were very clear right from the beginning. There are two risks to manage here. One risk is clearly cross-infection risk, which is why you're asking staff to be vaccinated in the first place. But the second is potentially the loss of staff. And as Elaine was explaining, trusts have been working incredibly hard to understand why individuals, even though it's safe, even though the advice is clear, even though their peers are being vaccinated, the evidence is very clear, which is it's those peer-to-peer conversations that actually are persuading people. So we've been working very hard at that, but clearly there is a very, very significant concern that come the deadline, there will still be large numbers of people who haven't been vaccinated. And I'll just give you one very simple illustration. I was talking to a chief executive last week who said that 40 of their midwives on their midwifery service, and interestingly, this can go in groups, 40 of their midwives basically were saying they were not prepared to be vaccinated. Those staff, given their skills and their expertise, are not particularly easily redeployed, but they're also extremely difficult to replace. So effectively, we know before we went into COVID, we had problems in terms of maternity staffing, and that chief executive is seriously concerned about the safety of the service if they have that number of people who basically refuse to be vaccinated. So there are some.
So where do you come down? I appreciate it's a really difficult question, which is why I'm asking it. Well, but if you had a vote this afternoon, which way would you be casting it?
I would be voting in favour of mandatory vaccination. But interestingly, when we polled our chief executives and our chairs, there was a 2/3, 1/3 split. 2/3 were in favour of mandatory vaccination, 1/3 weren't, because of the scale of the workforce loss risk. And at this point, that's got to be a major issue.
Thank you very much.
Okay, if that's all right, I'm going to move on to the next question. Thank you so much, Caroline. Philippa Whitford.
Thanks very much, Leila. If I could start with Chand. In the first panel, we heard Professor Reicher talking about, obviously, the length of time to boost people, the length of time for the boosts to work, and obviously how big Omicron could be by that stage. So do you think that what's being talked about as Plan B in England goes far enough to actually stop the NHS falling over, okay, or coming under relentless pressure somewhere between Christmas and New Year?
Unfortunately, I don't think it will be sufficient for the reasons I gave. Firstly, that even if we were to give a booster to all eligible adults, you're going to enter January with about 11 million adults unvaccinated because they're not yet eligible to have the booster. So we have a real problem that the population will continue to be, and in fact, out of those 11 million who won't have been vaccinated with a booster in January, many of them will be younger, where in fact the infection will be spreading the greatest. So we're going to have parallel infection control measures in public settings, in the community, as we move forward.
So now, what would you add, just trying to, because we're very short in time, what are the key things you would add to Plan B?
First of all, hospitality. It makes no sense that staff in hospitality don't have to wear a mask. A waiter serving customers in a crowded restaurant is just as able to transmit the virus. Make that mandatory now, straight away. Secondly, have specifications on physical distancing. Again, having a restaurant or a club or a bar or a pub with people crowded next to each other doesn't make sense. I do think, and that where there is going to be financial detriment on businesses, and I do feel for many whose livelihoods are at stake if they don't earn money, then there needs to be financial recompense by the government, remembering that if this is going to reduce pressure on the NHS, you are going to be saving by not having to treat patients in the same way. I also think there needs to be much clearer enforcement. We're a nation where, in fact, if anyone's been to Europe, and I haven't, but I spoke to many who have, there seems to be enforcement in other nations. Over here, there's a laissez-faire approach where you have a diktat from government, but no one's out there making sure that that people do what they should be doing. We need to have specifications on ventilation. No point saying we should ventilate environments when in fact there should be specifications of what that means in restaurants, in indoor settings, in shops, etc., including providing support for things like filtration units, which do and can work and aren't prohibitively expensive. Those measures with enforcement would make a difference. And we are calling for the public to be protected with FFP2 masks, especially those that are clinically vulnerable, because actually the current face coverings will not protect the wearer. And if that is implemented, as in other nations, it will reduce the risk of many being infected.
Okay, thanks very much. Dr. Henderson, what would you want to see, or do you feel that Plan B, as it is in England at the moment, goes far enough to make the difference we need in the coming days?
I don't really think this is something that's, this is not my area of expertise. This would just be a random doctor's medical opinion. I know what's going on the front line, but I don't think my views on what would be the next thing to do is particularly valuable to you, to be honest.
Okay, but do you think we need more, without going into the specifics of what it is, just looking at the curves of where Omicron could reach within a very short period of time?
Yes, we clearly are not holding the situation. We've got an organism that is spreading incredibly fast. We are in a system that's under a lot of pressure, and we're taking risk decisions all the time. But the risk, unfortunately, at the moment is that harm is going up rather than down.
Okay, I don't know whether Chris or Elaine, if you've got anything that you want to add at this point.
Happy to pass on ground of time.
Okay, thank you both.
Thank you both. Baroness Masham.
Will a surge in cases and hospitalisation have an impact on the vaccine rollout? And GPs having to vaccinate, what will happen to all their other patients, such as cancer diagnosis? Should they go straight to secondary care? Could we have Dr. Chand?
Thank you very much, Baroness. And I'm glad you are actually highlighting the impossibility of being in two places at once. And I just hope that message is understood, or the government explains that to the public. I think we have to have a balance, because we cannot ignore the patients that we see or need to see us who may have suspected cancer. And unlike the first wave, we need to have a system where the NHS continues to operate for urgent patients, whilst at the same time continuing the booster program. That will mean prioritization. It will mean that some with so-called routine care will need to be delayed. But the example you give of someone with suspected cancer should definitely be seen in general practice. I don't think we can ask them to go straight to secondary care, because actually hospitals are bursting at the seams, and they won't be able to just take on more patients in that way. But what will have to happen is honestly that there are going to be a sector of patients with some non-urgent chronic conditions that may not be able to be immediately seen, but we need to do this systematically.
It's a problem. Who else would like to come in?
Well, I can give you a secondary care perspective, which it's difficult to answer the question at this point, because we don't know how many secondary care staff are going to be reallocated over the next few weeks to help with vaccination. And clearly, again, Chan's got it absolutely right. It's impossible for people to be in two different places at once, but we're literally right in the process of working through today, tomorrow, and earlier on this week, we've started yesterday working out how many staff can be transferred across. And Catherine's right to flag the dangers of taking people off ordinary care, ordinary secondary care, and it will undoubtedly have an impact on patients. But if you accept the argument, which I think has been very consistently made, that the booster, getting as many boosters done as possible, as quickly as possible, is fundamental to protecting the health of the nation, and that the Prime Minister and the government have asked that this be the top priority, it be a national mission, then clearly what would happen would be that if we've got significant numbers of secondary care staff helping out on vaccinations, if we see a surge in hospitalizations before that campaign is completed, there will be some very difficult decisions to make about whether those staff return or not. So this is literally a very, very live issue. But the one thing I would want to reinforce really is the point that we definitely have now reached the place where we cannot do everything, and we are going to have to prioritize. And in our view, it's right that that those decisions within a national framework should be made by local leaders who effectively have got the best, I think, overview of where the risk is greatest. But we are now at that point very clearly.
Thank you. Dr. Catherine?
So I have concerns about this because I feel that the situation we're in now is going to widen health inequalities fairly dramatically, because those who with the most agency will take it into their own hands when they are realizing that we have got to stop and we are not able to provide, say, a diagnostic service around early cancer diagnosis. And what we will see is that the people who are able to either find care some other route or are very vocal, get in touch with people of influence and become very vocal and then get an appointment, we will see a situation where we're getting a widening of health inequalities. And it's again, I think it is about the communication. It has to be clear to the public the actual situation we've been in. And I think we from the Royal College of Emergency Medicine have been making this case for some time, that the messaging to the public has not been clear about how much strain the system is under. And that was before Omicron. This is not that we can't, my real worry is that Omicron gets used as a kind of an excuse for lots of bad things happening. And those bad things were happening before Omicron came along. Omicron is just making a bad situation worse. And yes, we obviously have to deal with that. And as Chris says, it is now a national mission to get the vaccination program. But it isn't we've got a whole load of blow up vaccinators in a cupboard somewhere that we've been keeping on standby for this situation. It's the same people who are, managing patients on the wards or taking somebody to theatres. It's the same healthcare professionals, unless we do manage to pull people who have exited the system back in. And that may be third sector, that may be the only way that we can do this. We get people back involved, but it is going to widen the difference between the people who can be vocal and the people who can't. And we already know that those are the people who have the worst healthcare outcomes as it is, let alone in this scenario. So I think we need to be really careful that that doesn't just become a disaster, that becomes a generational disaster as well.
Thank you so much. And Elaine?
Nothing else to add than the panel's already said. Thank you.
Just to say how important you all are. Thank you.
Hear, hear. And to the last question, Barbara Keeley.
Thank you. Well, you've given us some real food for thought, but can you all just give us your final key message or recommendation for the government? Could I start with you, Elaine?
Yeah, well, my key message would be, well, we've listened to 3 amazing experts the first session today. So the government, my message would be to really start listening to these experts who know what they're talking about. They will damage limitation. They will. So that would be my message.
Thank you. Catherine?
Value the nursing staff. We need a message that has been quite clear how important our nursing staff are, and any way that we can of rewarding nursing staff, because at the minute nursing staff are leaving the NHS or they're moving to less pressured posts. And I think we have broken our nursing staff nationally. And if we don't get it right with them, everything is going to be much more difficult going forward.
Thank you. Chand?
First is, my key message is, please be honest with the population about the scale of the problem. Be honest about the impossibility of doctors like myself, healthcare workers, being unable to deliver everything that we would like to, and so that we don't get blamed when we can't be in 2 places at once and can't do everything we'd like to, and value us and value our well-being. We are exhausted. And the third thing, a key message, is that you have to have a policy that isn't just about boosters. It has to be about public health interventions that will prevent spread of this virus, because that has to be a key approach, which at the moment doesn't seem to be getting the same prominence. And that does mean going further than some of the restrictions under Plan B.
I think your messages are very loud and clear today, and that's really helpful. Chris, can I come to you? What's your key message to the government?
Well, it's one that I think is a cause that's close to your heart, Barbara, which effectively is we haven't talked about social care at all. And I'm very, very struck that when I talk to our trust chief executives and I say, what's the one thing you would like done? They basically say emergency support for social care. I think, as you know, 11% of NHS beds last week were occupied by medically fit to discharge patients. It's not just about social care, it's also about other NHS care that they need access to. But there's been a very, very significant increase in the level of pressure on our social care colleagues over the last 2 or 3 months, particularly in terms of workforce. So we were talking a couple of weeks ago about can the government fund a winter retention bonus? But I think the real key is an emergency injection of extra support into social care, because that is absolutely fundamental.
Excellent. Okay, thank you. Back to you, Leila.
Thank you very much. Well, it just leaves for me to say, my goodness, I feel like as ever, but especially this session, we could have had double the time and still probably not got through all of our questions. I just want to thank you all individually and collectively for giving us your time, your very precious time this morning, to echo what Baroness Masham said, which is just to thank you for your work. Again, to thank the colleagues and everyone that you represent for what they do. The debate on coronavirus Plan B, plan insufficient, is clearly the message that's come out of today, and I intend to go into the chamber and try and make that point. But thank you, all of you, for your time. Thank you to the parliamentarians. Thank you to everyone who's been watching at home. Goodbye and stay safe. Thank you.